You have two kinds of fat in your body right now. One you can see, one you cannot. The one you cannot see, the fat wrapped around your liver, your pancreas, your intestines, that fat is actively, measurably, silently raising your risk of cancer, heart disease, and organ failure. And the terrifying part is this. You can be slim. You can have a flat stomach. You can pass every visual test you've ever given yourself in the mirror, and still have dangerous levels of it building right now. I'm Dr. Zhang, and in the next 30 minutes, I'm going to show you exactly what this fat is doing inside your body at the cellular level, why it accelerates after 50 in a way most people are completely unprepared for, and the 3 evidence-based interventions that have been shown in peer-reviewed clinical trials to reduce it, starting this week. Stay with me, because what I'm about to show you changed the way I practice medicine. I want to tell you about a patient I'll call David. He was 54 years old, athletic build. He came into my office for a routine checkup. He ran 3 times a week. His BMI was 23.4, technically perfect. By every external measure, David was a healthy man. But David had been feeling tired. Not dramatically tired, just slower than he used to feel. His energy in the afternoons had been fading for about 2 years. He'd started needing coffee after lunch. He'd gained about 6 pounds over the last 3 years despite not changing his diet. His doctor the previous year had told him everything looked fine. I ordered a DEXA scan. I ordered a full metabolic panel. And what came back stopped me. David's visceral adipose tissue, the fat surrounding his internal organs, was in the top 15% for his age and sex. His liver enzymes were elevated. His fasting insulin was twice what it should have been. His C-reactive protein, a marker of systemic inflammation, was 4.2 milligrams per liter, in the range consistently associated with significantly elevated cancer risk. David didn't have a weight problem. David had a silent fat problem. And the difference between those two things may be the most important distinction in modern preventive medicine. Here's exactly what we're going to cover today. First, I'm going to explain what visceral fat is, where it lives, and why the medical community is only now beginning to understand how dangerous it truly is. Second, I'm going to walk you through the specific biological mechanisms by which visceral fat drives cancer. And this is the part that most health videos skip entirely. I'm going to take you inside the cell. Third, I'm going to explain why, after 50, your body shifts into a state that accelerates visceral fat accumulation in a way it simply did not do in your 30s and 40s. And fourth, the part I know you're here for, I'm going to give you the 3 evidence-based interventions with exact protocols that the clinical research shows will reduce visceral fat, reduce systemic inflammation, and significantly lower your risk of the diseases it causes. No supplements I'm selling, no program I'm promoting. Just the science, translated into something you can actually use. Let's start. When most people think about body fat, they're thinking about subcutaneous fat, the fat that sits just beneath the skin, the fat you can pinch, the fat you can see when you look in the mirror. That fat is not the primary thread I'm talking about today. Visceral fat is stored deep inside the abdominal cavity, wrapped around your organs, your liver, your pancreas, your intestines, your kidneys. It is sometimes called intra-abdominal fat or organ fat, and it is metabolically unlike any other fat in your body. Subcutaneous fat is relatively inert. It stores energy, but is not aggressively metabolically active. Visceral fat, by contrast, behaves like a dysfunctional organ of its own. Visceral fat cells are larger, more insulin-resistant, and far more metabolically active. They release a constant stream of signaling molecules, adipokines, cytokines, free fatty acids, directly into the portal vein, which drains straight into your liver. Every hour of every day, your visceral fat is conducting a private chemical conversation with your liver, and the messages it's sending are inflammatory. Inflammatory signals that reach the liver first, before any other organ, before dilution in the systemic circulation. The liver absorbs this flood of signals, becomes inflamed, and begins to accumulate fat of its own, a condition called non-alcoholic fatty liver disease, or NAFLD, from which the cascade of damage spreads to every system in your body. Let me give you the scale of this problem. According to data from the National Institutes of Health, non-alcoholic fatty liver disease now affects an estimated 80 to 100 million Americans, 1 in 3 adults in the developed world. And the majority of those people have no idea, because NAFLD is silent. It produces no pain in its early stages. Liver cells don't have pain receptors. The organ can be 30% infiltrated with fat, and you will feel nothing except perhaps that same vague fatigue that David described. A major review published in the journal Nature Reviews Gastroenterology followed over 49,000 patients with NAFLD and found that those with advanced liver inflammation had a risk of dying from liver-related disease that was 6 times higher than those without it. But here is the number that stopped me cold when I first encountered it in the literature. They also had a significantly elevated risk of dying from cardiovascular disease, from kidney disease, and from certain cancers, particularly liver cancer, colorectal cancer, and breast cancer. Visceral fat is not just an aesthetic problem. It is not just a diabetes risk factor. It is a systemic inflammatory engine driving disease across multiple organ systems simultaneously. And after 50, it accelerates. I'll explain exactly why in a moment, but first I want to take you inside the cell, because understanding the mechanism is what changes behavior, not fear alone, understanding. I want to explain something that is genuinely underappreciated, even among physicians, about how visceral fat drives cancer, because the connection is not vague. It is not statistical correlation. It is a specific, well-characterized biochemical cascade, and once you understand it, you will never look at your waistline the same way again. It begins with something called adipose tissue macrophage infiltration. As visceral fat expands, as the adipocytes get larger and more numerous, they begin to die. Fat cells that have grown too large undergo cellular stress and die, releasing a distress signal called monocyte chemoattractant protein 1, or MCP1, which recruits macrophages from the bloodstream. These macrophages activate and begin producing pro-inflammatory cytokines, tumor necrosis factor alpha, interleukin-6, interleukin-1 beta. These inflammatory molecules enter the portal circulation. They reach the liver. They trigger hepatic inflammation. They reach the systemic circulation. And they begin doing something that the cancer research community has been documenting with increasing clarity over the past 15 years. They create a pro-tumorigenic environment, an internal environment that favors cancer cell survival, proliferation, and metastasis. Here is the specific mechanism the science has established. Chronic inflammatory cytokines stimulate a signaling pathway called NF-kappa B, nuclear factor kappa B. NF-kappa B is sometimes called the master regulator of inflammation. When NF-kappa B is chronically activated, it upregulates the expression of genes that promote cell proliferation and suppress cell death. Genes like BCL2, genes like cyclin D1. These are exactly the genes that drive cancer cell growth. Visceral fat also drives chronic hyperinsulinemia, elevated fasting insulin levels. Visceral fat cells are insulin resistant, meaning the pancreas must produce more and more insulin to try to move glucose into cells. That chronically elevated insulin is not a passive bystander. Insulin activates the insulin-like growth factor 1 receptor, IGF-1R, on cell surfaces throughout the body. IGF-1R activation is one of the most potent stimulators of cellular proliferation and inhibitors of apoptosis, programmed cell death, known to oncology. When IGF-1R is chronically stimulated, cells that have accumulated DNA mutations are less likely to die as they should. They are more likely to proliferate. Visceral fat also drives estrogen production through peripheral aromatization. Fat tissue contains aromatase, an enzyme that converts androgens into estrogens. Elevated estrogen levels, independent of their source, are a well-established driver of breast cancer, endometrial cancer, and potentially prostate cancer. This is in every major oncology textbook. And then there is a fourth mechanism, which I consider the most underappreciated of all. Chronic inflammation from visceral fat suppresses natural killer cell activity. Natural killer cells, NK cells, are your body's first-line immunosurveillance against cancer. Their entire biological purpose is to identify cells that have undergone malignant transformation and destroy them before they can establish a tumor. A landmark paper in cancer immunology research demonstrated that individuals with elevated visceral fat had significantly impaired NK cell cytotoxicity. The cancer surveillance system was compromised, not by a disease, not by a medication, but by fat wrapped around their organs. A large prospective cohort study published in the British Journal of Cancer followed over 43,000 adults across a 14-year period. After controlling for BMI, overall weight, physical activity, and diet quality, they found that individuals with high visceral fat, independently of how much they weighed, had a 33% higher risk of developing colorectal cancer and a 28% higher risk of developing liver cancer. Independent of body weight. Not about being overweight, this is specifically about visceral fat. When I explain this to my patients, the room changes. There is a quality of attention that shifts, because this is no longer abstract. This is happening inside the body, right now, in people who believe they are fine. David asked me a question when I showed him these findings. Dr. Zhang, why did none of this show up on my regular blood tests? Standard annual blood panels in most primary care settings check total cholesterol, HDL, LDL, triglycerides, fasting glucose, and basic liver enzymes. They do not routinely measure fasting insulin. They do not measure C-reactive protein or interleukin-6. They do not assess visceral adipose tissue volume. The tests your doctor orders at your annual physical were largely designed to catch diseases that have already developed, not to detect the pre-disease inflammatory environment that visceral fat creates over years before a diagnosis is made. A 15-minute annual visit cannot do what I am doing with you right now. That is exactly why channels like this exist. Now let me tell you about a biological shift that happens in your body between ages 45 and 55 that almost nobody explains. It is called ectopic fat redistribution, and it is driven by hormonal changes that are universal, predictable, and largely invisible to the person experiencing them. In your 20s and 30s, sex hormones, estrogen in women, testosterone in men, play a significant regulatory role in fat distribution. Estrogen in women actively promotes the preferential storage of fat in subcutaneous locations, the hips, the thighs, the buttocks. This is hormonally mediated and it is protective. Subcutaneous fat in these locations is relatively benign. It is not the organ-infiltrating, cytokine-secreting, portal vein flooding fat we've been discussing. As estrogen levels decline in perimenopause and menopause, a process that can begin subtly as early as the mid-40s, this subcutaneous fat preferential storage pattern changes. The hormonal signal that directed fat to the hips and thighs weakens, and fat increasingly migrates to visceral depots, the same total body fat, redistributed. Studies tracking women through the menopausal transition have documented increases in visceral fat volume of 40 to 50% across the menopausal transition period, even when total body weight remained stable. In men, the parallel change involves declining testosterone. Testosterone actively promotes lean muscle mass and suppresses visceral fat accumulation. As testosterone declines, and it typically begins a measurable decline after 40, accelerating through the 50s, the suppressive effect on visceral fat accumulation weakens. A large meta-analysis published in the European Journal of Endocrinology found that men with low testosterone had, on average, 36% more visceral fat than age-matched men with normal testosterone, after controlling for total body weight. But the hormonal shift is only part of the story. There is a second mechanism accelerating after 50 that compounds the hormonal changes: mitochondrial decline. Your mitochondria are the energy-producing organelles inside every cell. They are the structures that burn fat for fuel. At 30, a single muscle cell may contain 2,000 active mitochondria. By 65, published studies measuring mitochondrial density directly from muscle biopsies document an average decline of 40 to 50%. Your body's fat-burning machinery has been cut in half. And here is where it compounds. As mitochondrial function declines, the metabolic flexibility of your cells decreases. Metabolic flexibility refers to your cell's ability to switch between burning carbohydrates and burning fat depending on availability. Metabolically flexible cells easily shift into fat oxidation mode during low carbohydrate intake, during sleep, during exercise. Metabolically inflexible cells default to glucose dependence and become less effective at mobilizing stored fat. What this means practically: the same diet, the same exercise routine, the same lifestyle that maintained healthy visceral fat levels at 40 begins to fail at 52, at 55, at 58. Not because your habits changed, but because your cellular machinery changed. After 50, the liver's capacity to clear fat from the portal circulation also begins to decline. Hepatic fat clearance depends on mitochondrial function within liver cells, and as mitochondria decline, the liver retains fat rather than clears it. And there is a fourth factor, which I want to name specifically because it is almost never discussed. Visceral fat itself is inflammatory, and chronic inflammation impairs mitochondrial biogenesis, the process of building new mitochondria. This means that once visceral fat begins to accumulate, The inflammation it generates actively suppresses the cellular machinery that would help burn it. It is a self-reinforcing cycle. Visceral fat accumulates, produces inflammation. That inflammation suppresses mitochondrial function. Reduced function reduces fat-burning capacity. More visceral fat accumulates. This is why the decade between 50 and 60 is so critical, and the window to interrupt it narrows with each passing year. Now let me tell you what the evidence actually shows works. And I am not going to give you the general lifestyle advice you have already heard. These are specific interventions with specific protocols from published clinical research, measured outcomes from randomized controlled trials. The first intervention is time-restricted eating. Compress your eating into a daily window of 8 to 10 hours and stop eating at least 3 hours before you sleep. Here is the mechanism and the evidence. Visceral fat is preferentially mobilized during periods of low insulin. Insulin is a storage hormone. When insulin is elevated, as it is for several hours after every meal, fat mobilization from visceral depots is biochemically suppressed. Conversely, during fasting periods, when insulin falls and glucagon rises, visceral fat oxidation accelerates disproportionately compared to subcutaneous fat. Visceral adipocytes are more sensitive to lipolytic signals in the fasted state. This is a feature of their biology. A randomized controlled trial published in Cell Metabolism assigned 90 adults with metabolic syndrome, including elevated visceral fat, to either time-restricted eating with an 8-hour eating window or a control diet with the same caloric content. After 12 weeks, the time-restricted eating group lost an average of 3.6 kilograms of body fat. But the more significant finding was in the composition of that fat loss. MRI measurements confirmed that visceral adipose tissue volume decreased by 14% in the time-restricted eating group compared to 7% in the control group. The same total fat loss, but nearly twice the visceral fat reduction with time-restricted eating alone. The specific protocol. Begin eating no earlier than 2 hours after waking. Stop eating at least 3 hours before sleep. This naturally creates an eating window of 8 to 10 hours for most people with a conventional schedule. Why the 3-hour rule before sleep matters specifically. Hepatic fat clearance. Your liver's ability to export fat is most active during sleeping hours when parasympathetic nervous system activity is dominant. If you eat a large meal within 2 to 3 hours of sleeping, you redirect liver metabolic activity away from fat clearance and toward food processing. The research on NAFLD progression consistently identifies late-night eating as one of the most significant modifiable behavioral risk factors for hepatic fat accumulation. David implemented this single change and nothing else for the first 4 weeks. At his follow-up, his liver enzyme levels had decreased by 31%. His fasting insulin had dropped from 18.4 to 11.2 micro-IU per milliliter. These are meaningful clinical changes produced by shifting the timing of his meals, not the content. The second intervention is Zone 2 aerobic exercise. Not all exercise reduces visceral fat with equal efficiency, and the type you choose matters. Zone 2 is aerobic exercise at an intensity where you can hold a conversation, but it requires effort. Technically, it corresponds to approximately 60 to 70% of maximum heart rate, or the intensity at which blood lactate remains below 2 millimoles per liter. It feels like a brisk walk, a comfortable jog, a moderate-paced cycling session. Why does Zone 2 specifically target visceral fat? During Zone 2 exercise, the primary fuel substrate is fat, specifically free fatty acids mobilized from adipose tissue. The biochemistry favors fat oxidation at this intensity because the aerobic metabolic pathways, beta oxidation within mitochondria, run most efficiently at moderate intensities. At higher intensities, the body increasingly relies on glucose and produces lactate. Zone 2 is the sweet spot where fat oxidation is maximized. The visceral fat-specific mechanism. Visceral fat cells have a higher density of beta-3 adrenergic receptors than subcutaneous fat cells, the receptors that respond to sympathetic nervous system signals to release stored fat. During Zone 2, catecholamines are released at levels that effectively stimulate these receptors in visceral depots. A meta-analysis of 16 randomized controlled trials published in Obesity Reviews, encompassing over 800 participants, found that aerobic exercise reduced visceral fat volume by an average of 6.1% independent of changes in body weight. That is, participants who did not lose weight but exercised aerobically still reduced their visceral fat. The fat was redistributed. mobilized from visceral depots and oxidized for fuel during exercise. The specific protocol? 150 to 200 minutes of Zone 2 aerobic exercise per week. That is 30 to 40 minutes, 5 days a week. The intensity must be maintained in the moderate zone, not walking slowly and not running hard. A useful test. You should be able to say a full sentence, but need to take a breath before completing a long one. Too easy? You're below. Can't complete a sentence? You're above. For patients who cannot exercise at this intensity due to joint conditions, swimming and cycling are highly effective alternatives that achieve Zone 2 heart rates with significantly lower joint loading. One more detail I want to add because it significantly amplifies the visceral fat reduction effect. Perform your Zone 2 session in the morning, 2 to 3 hours after waking, before your first meal. This places your exercise in the low insulin post-overnight fast period when visceral fat mobilization is already elevated. A study published in the Journal of Clinical Endocrinology and Metabolism found that Zone 2 exercise performed in the fasted state produced visceral fat oxidation rates 29% higher than the same exercise performed after a carbohydrate meal. The third intervention is the anti-inflammatory dietary pattern, and I'm going to give you not a complete dietary overhaul, but 3 specific dietary additions that the clinical evidence most consistently associates with reduced visceral fat, reduced hepatic inflammation, and reduced cancer risk biomarkers. Complete dietary overhauls have notoriously poor long-term adherence. 3 specific additions are achievable. The first is extra virgin olive oil. Not vegetable oil, not light olive oil, specifically extra virgin olive oil, consumed daily as the primary cooking fat. Extra virgin olive oil contains a compound called oleocanthal, which inhibits cyclooxygenase enzymes, the same enzymes targeted by ibuprofen. It also contains oleic acid and a class of polyphenols including oleuropein and hydroxytyrosol that have been specifically studied for their effects on liver fat. A randomized trial published in the Journal of Hepatology assigned participants with confirmed NAFLD to either a Mediterranean diet with extra virgin olive oil or a low-fat control diet. After 18 months, the Mediterranean diet group showed a 46% reduction in liver fat content as measured by MRI spectroscopy, the gold standard measurement. The control group showed a 6% reduction. 4 tablespoons of extra virgin olive oil per day was the dose used in the clinical protocol. The mechanism: oleic acid and olive polyphenols activate PPAR-alpha, a nuclear receptor that upregulates hepatic fat oxidation. They reduce NF-kappa B activation and the inflammatory cytokines secreted by visceral adipocytes. The second food is fatty fish, salmon, sardines, mackerel, anchovies, consumed at a minimum of 3 times per week. Fatty fish provide EPA and DHA, the long-chain omega-3 fatty acids. These have been studied extensively for their effects on visceral fat and hepatic inflammation. EPA and DHA are incorporated into cell membrane phospholipids, where they compete with arachidonic acid, the precursor to pro-inflammatory eicosanoids, and shift the inflammatory balance toward resolution. They activate PPAR-gamma in adipocytes, which promotes healthy fat cell differentiation over the pathological enlargement pattern associated with visceral fat dysfunction. And they significantly reduce serum triglycerides, the circulating fat most directly correlated with hepatic fat accumulation. A systematic review and meta-analysis published in the journal Nutrients, covering 18 randomized controlled trials and over 1,100 participants with NAFLD, found that omega-3 supplementation significantly reduced liver fat content, liver enzyme levels, and systemic inflammatory markers including C-reactive protein and interleukin-6. The effect size was dose-dependent and clinically meaningful, beginning at 2 grams of combined EPA plus DHA per day, achievable with 3 servings of fatty fish weekly or a high-quality fish oil supplement. The third food is fermented foods daily: plain yogurt with live cultures, kefir, kimchi, or sauerkraut. The link between gut microbiome composition and visceral fat accumulation is one of the most important developments in metabolic medicine in the last decade. The gut microbiome of individuals with high visceral fat and NAFLD is consistently characterized by reduced microbial diversity and overgrowth of gram-negative bacteria that produce lipopolysaccharide, or LPS. LPS is a component of gram-negative bacterial cell walls. When the gut barrier is compromised, which it consistently is in the context of high visceral fat, LPS leaks across the intestinal wall into the portal circulation and reaches the liver. In the liver, LPS binds to toll-like receptor 4 on Kupffer cells, the liver's resident macrophages, and triggers a powerful inflammatory response. This LPS-driven hepatic inflammation is now recognized as one of the primary drivers of NAFLD progression from simple fatty liver to the inflammatory and fibrotic form of the disease that carries significant cancer risk. Fermented foods, through the provision of live bacteria and the compounds they produce, have been shown in multiple clinical trials to improve gut barrier integrity, reduce circulating LPS levels, and shift microbiome composition toward anti-inflammatory species. A 2022 study from Stanford, published in Cell, randomized 36 healthy adults to either a high-fiber diet or a high-fermented food diet. The fermented food group showed significant increases in microbiome diversity and significant reductions in 19 inflammatory proteins, including interleukin-6 and interleukin-12, two of the cytokines most strongly associated with cancer progression. Here is what almost never appears in health videos on this topic, and perhaps the most important thing I can tell you. The three interventions work through overlapping mechanisms that reinforce each other, and their combined effect is not additive. It is multiplicative. Here is why. Visceral fat reduction improves insulin sensitivity. Improved insulin sensitivity reduces fasting insulin. Reduced fasting insulin lowers IGF-1 receptor activation. Lower IGF-1R activation reduces cancer cell proliferation signals. Meanwhile, omega-3s and olive oil are simultaneously reducing the NF-kappa B activation that drives cancer gene expression. And Zone 2 exercise is simultaneously improving NK cell cytotoxicity, the immune surveillance capacity that was being suppressed. You are not doing three things. You are interrupting the same inflammatory cancer-promoting cascade from three different angles simultaneously. The patients I have seen make the most dramatic improvements are consistently the ones who implement all three together, not sequentially, not partially. All three, consistently, for 12 weeks. I want you to start this week, not next Monday, not after you finish this video and think about it. This week, because every week that this inflammatory environment persists, the processes I have described are continuing. David came back to me 6 months after our first conversation. He had implemented time-restricted eating. He had started morning Zone 2 walks, 35 minutes, 5 days a week. He had added olive oil, salmon twice a week, and daily yogurt. His repeat metabolic panel showed fasting insulin down from 18.4 to 7.8, C-reactive protein down from 4.2 to 1.1, out of the elevated risk range entirely. Liver enzymes normalized. And his follow-up DEXA scan showed a 22% reduction in visceral adipose tissue volume. David did not take a medication. He did not undergo a procedure. He made 3 evidence-based changes and sustained them. I want that for you. But I need you to act now, not when it's convenient, because convenient is what your biology is counting on. If this changed how you think about your health, please share this video with one person over 50 in your life. Not because it helps my channel, but because it could genuinely change the trajectory of their health. Subscribe if you haven't already, because every week I release a video covering exactly this kind of evidence-based science, the protocols, the research that your doctor simply does not have time to explain in a 15-minute visit. And in my next video, I'm going to reveal something that shocked me when I first read the research. One of the most commonly eaten breakfast foods in Western countries is silently spiking your visceral fat every single morning, including some foods marketed specifically as heart-healthy. I'm going to show you exactly what it is and what to replace it with. I'm Dr. Zhang. Thank you for being here. And remember, understanding your body at this level is not a luxury. It is the most important thing you can do.